that we are supposed to treat, mostly aneurysms and dissections in the arch. And this is obviously difficult. Looking into one of the largest series in the world from our friend in Hanover, even in very young patients, median age of 63, we see open repair has a significant operating mortality and also secondary interventions. So therefore, there is the other alternative of endovascular treatment. Obviously, critics of this treatment would say that there will be important complications, which is true, and the durability as of this point of endovascular treatment is still questionable. And there is obviously also effective and still improving surgical treatment. So I would still like to say that for fit patients at this time, even in our hospital, we would refer the patients to our cardiac surgeons. The problem in Asia is that the patients do not want open intervention for fear of serious complications. So that's why we vascular surgeons will come in. As you know, there are all these methods of landing in the arch, branching, chimneys, fenestrations, in situ fenestrations, and branch endografts, and all these methods do have some kind of compromise one way or another. You have compromise in mobility, compromise in seal, if you do chimney, problem with fixation, if you do in situ fenestrations, there may be durability issues, and for internal side branch endograft, there would be the issue of stroke. So you come to first the hybrid procedures in this excellent comparison by Dr. Bavaria, or comparing open and endovascular repair. He noted that there are significant neurological deficits, but similar comparing hybrid and open repairs. However, there are significant differences in mortality when it comes to elderly patients. So the conclusion was that hybrid arch repair provides a safe alternative. However, you look at this recent meta-analysis of 18 studies of hybrid arch repair of about 195 patients, there are indeed significant issues of endoleaks, 9%, and also mortality and mobility, 9% mortality and 20% mobility. So this is not an operation that is completely free of danger. So in fact, we've literally very much abandoned the hybrid arch procedures in favor of other endovascular options. Long-term, we see complications of branch occlusion, complications associated with inadequate landing zone, graft migration. So these things are obviously very difficult to treat. What about chimneys? Chimneys on parallel graft, we can do this for the subclavian artery, we can even do this for the left common carotid arteries, that is the field complications of type 1A endoleak. This is one of our patients which seemed to have a perfect chimney placement anatomically, but he did have a type 1 endoleak afterwards. So the largest single series was more than 100 patients from this series in China. Note that the majority were carotid artery chimneys and the majority were on aortic dissections. And even in this large series, the type 1A endoleak was almost 11%. There are three recent, within these 5 years, meta-analysis on arch chimneys. They may be on the same patients, but it's 100 patients, 130, and the largest recently published series of 364 chimneys in 300 patients. Note that although this can be done with a reasonable low mortality, the major issue of chimneys would be a type 1A endoleak, whether this is early, almost 10%, and some of these would be still late endoleak. So this would be the Achilles heel of chimney endografts. We do have scallops that you can make. This is the Bolton, the Turomo relay scallop that you can align with the left common carotid artery. You can combine this with a fenestration, which is custom made in this Cook device, where there will be a preloaded wire and catheter that you can grasp from the carotid and use this to achieve a combined scallop and fenestrated approach for the arch. There is not that many series or results published regarding fenestration and arches fenestration and scallops in the arch. This is but one of the series from London, 20 patients, low mortality, but indeed the stroke rate is still significant at 14%. In situ fenestrations, I leave Dr. Xu, who would be an expert in China. There's very large numbers done in China, but in fact the earliest one was really done in 2004, followed by 2008 in the arch by doctors in Sweden. So there are a number of devices rather ingenious now, again mainly made in China, using either laser or a